All right, so today we're very honoured to have Professor Nick Goodwin presenting at the Australian Institute of Health Innovation Implementation Science Interest Group. And I'm sitting in for Karen Hutchinson, who actually organised this session. Unfortunately, Karen can't make it this afternoon, so I will take you through and introduce Nick and facilitate the session. So I'm Yvonne Zawinski. I'm Associate Professor of Health System Sustainability and I'll chair today. We aim to hold relatively informal webinars in a very collegial environment, and we very much value your input and questions. So please post your questions in the chat or simply unmute yourselves at the end of this session, and it's really important to have a really good discussion. Okay, it's not advancing, and that's okay. I will just do an acknowledgement of country. We acknowledge the traditional custodians of the land on which Macquarie University is situated, the Wallumattagal clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the Dreamtime. We pay our respects to elders past, present and future. We also acknowledge the many different lands that all of our participants are joining from, and indeed my land that you can see virtually behind me. I'm currently on the land of the Wongal people of the Eora Nation on the southern banks of the Parramatta River in Sydney. So we've got Nick Goodwin with us today, which is absolutely fantastic. Nick is the director of the Central Coast Research Institute, this new institute, relatively new institute, is a joint venture between the University of Newcastle and the Central Coast Local Health District. And the main purpose of Nick's institute is to undertake translational research into the development and delivery of new models of integrated care that improve people's health and well-being. Nick has worked for the past 25 years in the field of health services research, management and policy. And he led the King's Fund's strategy on integrated care. He was also the co-founder and CEO of the International Foundation of Integrated Care that many of us are familiar with. Nick has worked also as a consultant on integrated care policy and practice across more than 25 countries worldwide, and edited the WHO's global framework on people-centered and integrated health services, which was ratified by the World Health Assembly. So we're very privileged to have Nick today talking about implementing integrated care, lessons for research, policy and practice. So over to you, Nick.
Thank you very much, Yvonne. It's very pleased to be here and join you all. I think we will make this as relaxed as possible, so I prepared a few slides and then we can have a good discussion about things. So I'll try and share my screen and hopefully this will work. This one, I believe. And then if I move this across. Okay, that should all be perfect on your screen now. Excellent. So yes, so the CCRI, as you say, is a new joint venture between the local health district and the University of Newcastle. And I think it was originally an idea that was created maybe almost 10 years ago, 10 years or so ago now, by some of the chief executives of the LHDs around what is it that we can do differently to be able to support our various communities in terms of gearing up for dealing with the future needs of healthcare and health systems. So in other words, how do we overcome the endemic fragmentations that we see in the way that we deliver healthcare services today, not just in Australia, but internationally, and what can we do about it? And the thing that attracted me to come, having been many years an advocate for this, one, of course, it's an adventure tour in Australia with a young-ish family, and it's something new, of course, but also what you see around the world is where you have a health system working alongside a university dedicated to supporting things like this, you can really make a difference to the health and economic well-being of the environment in which you're supporting, and you see that in different parts of the world. So I thought this would be a really interesting and worthwhile venture, focusing in on the Central Coast, but not just on the Central Coast, and what we could do. I think there's no need to really go into too much detail about the need for integrated care in Australia. I might say what my thought of integrated care is, because you see it in almost every policy document that you read, whether it is at a Commonwealth level or a state level. There's clearly been a concerted amount of thinking to different degrees of coherence and intensity around the integrated care agenda. Some of it as a means, or most of it as a means to reduce acute sector demand, but nonetheless greater attention and focus on how do we deal with the issues related to rural and remote issues, increasing numbers of people with complex chronic illnesses and mental health and so on. And perhaps more recently, the focus on how we do this through new technologies and virtual care, and of course the post-COVID conversations that we're having that are really focusing in on the same sorts of conversations we should have been having previously about how do we support people with complex chronic conditions and frailty within our communities more effectively through an integrated response. But the question is, for this presentation, what is it that we do about it? I think when we talk about integrated care, there are hundreds of different definitions, and it becomes all too complex and meaningless sometimes. Some people talk about integrated care as if it was just a stress term. We don't want the normal care, because that's like the normal food that you get. What we want is fresh food. So integrated care is not just care, it's integrated care. So it's given us this stress term and it begins to lose its meaning. What it really means is it's necessary, and it's necessary where fragmentations in the way to deliver care means that care has become so poorly coordinated around people's needs that it's leading to an adverse or suboptimal impact on their experiences and outcomes. And whenever you look at things like Aboriginal health or rural support to rural and remote communities, or people with complex chronic illnesses, or people with mental health and physical needs, people fall through the gaps all the time. And this needs to be overcome, because we need to simultaneously seek to improve the quality and cost effectiveness of the care that we provide by ensuring better care coordination around people's needs. And increasingly also, we need to ensure that people themselves, or their carers and families, are put much more in charge of their ability to manage their own health. Because when we talk about integrated care being people-centered, or indeed population-oriented, integrated care 101 is actually seeing people in the communities as co-designers and co-producers of their own health, rather than the system being more paternalistic, if you like, and looking down and saying, what is it that we can do to support you, rather than what we can do together. So really the people's perspective really is the organizing principle of service delivery at these different levels. So integrated care, relatively simple really. And can it bring benefits? People say, integrated care, we tried in Australia, it doesn't work. Well, the point is what you mean by integrated care. So where integrated care better coordinates care around people's need at the clinical and service level, in other words, at that interface, that transformational interface between healthcare professionals and people living in the communities or their carers, we know that it can improve quality of care and care outcomes really quite fundamentally. Where uncertainty remains is the relative effectiveness of different system level kind of interventions, the structural solutions that systems take to try to support that. So for example, issues related to the creation of new organizational forms, or bringing health and social care authorities together, or creating new alliances, or new governance, or new finance, or other types of approaches. And one of the reasons they are relatively ineffective or less effective than they could be is because the clinical and service level reform that's really the engine room of what you're trying to do gets crowded out of the conversation, because you're looking at system issues from a governance and incentive level, kind of at the high up, rather than going granular and thinking through what is it that we're really going to do differently that's going to allow us to get the outcomes that we're looking for. Getting the design and implementation of integrated care programs right takes time to innovate and mature. So what you see in integrated care programs around the world is it could take 3, 5, 7 and more years of a particular policy or program to work its way through before you begin to be able to see these real changes happen. I remember doing a piece of work for WHO Europe, looking at maybe I think 200 examples of different kinds of integrated care programs from across Europe of all different types and sizes. But one of the things that you saw was that most of them were only 1 or 2 years old and hadn't reached any level of maturity. The ones that were able to demonstrate impact and outcome, ones that have been going for 5 or 7 years. Unfortunately, the failure rate or the mortality rate of integrated care programs is very high for all sorts of reasons I'll go into. So therefore, the design and implementation is really important, but also it's the ability to provide the time to allow them to embed and mature. So in terms of implementation science, do we ever provide the time for these things to be looked at over a suitable period of years? And the answer is no, because we want to see instant gratification in order to deal with post-COVID issues, rather than think through what's this going to mean for the next 10 or 20 years and how do we get there in a mature and logical way. It's not just how political cycles work or indeed research. The other thing we find is research itself tends not to look at integrated care in the sense of how care is coordinated around people's needs or what is it that we do to support people's health and well-being outcomes. It tends to look at integration. So in other words, a virtual care approach, or how do we bring budgets together, or how we develop a new program. It's kind of at that abstract level of organizational delivery as opposed to what can happen through at a micro level between service users and professional teams. Valuations tend to fail to really look at that, and then they come up with saying, well, integrated care doesn't work. Well, you haven't been looking at integrated care, you've been looking at something rather different. You're looking at the processes that support integration. It's not the same as integrated care. So you end up with a lack of robust experience overall on the economic impacts of integrated approaches, with a lot of positive context specific case experiences. Having said that, recent meta-analysis reveal that cost savings are significant in those projects that can be defined as integrated care rather than just integration. So if we look at it over the long-term period and are able to understand that we're really doing integrated care with people at that local scale, you can see those cost savings happen as well as the good stuff in terms of care experiences and outcomes. A lot of that evidence is missing. One of the key problems, however, when it comes to implementation science is how do we explain the success and how do we explain the failure? And this can be really quite difficult, and I'll try and explain it in terms of one particular example back from the UK. So you've got the United Kingdom on the right-hand side there, although we're missing Ireland, but in the top northwest-hand corner, you've got Cumbria, beautiful part of the world, Lake District. It's rural, as much rural as you can get in the English context, not exactly the Australian rural. Lots of mountains and valleys and lakes and communities with not a great deal of good transport to different places. And as a result of that, they're vulnerable to a lot of shifts. And in 2014, in a small community of 8,500 people in Millom, which is somewhere to the southwest of that map, basically the community hospital had to close. And the reason it had to close is because one of the GPs retired and they weren't able to get a replacement. But instead of so they ended up with no services at all and very long journeys to try to get access to care. But what they decided to do was take an assets-based approach and embraced what is it that we can do collectively across all of our different community assets in order to provide services and support an approach that was embedded within the community. And within 5 years' time, the whole of Cumbria Morecambe Bay, so all of that area that you see on the left-hand side, about 750,000 people, was supported through 20 community-based alliances and became the fastest transforming integrated care system across the UK, from being right at the bottom of the public health outcome stakes to somewhere in the middle in a relatively short time, but turning a system that was financially unstable and in debt to one that was enabling an 8 to 10% year-on-year financial saving. So this is really quite a remarkable thing. But do we understand how they did it? And the answer is no. The lead GP in the system was a guy called Dr. John Howarth, and he's really interesting because he worked in disaster medicine historically and worked in places like Rwanda during the genocide and Afghanistan and places like that. So he's really interesting because he doesn't look upwards for things to happen. You know, I need more funding, or I need a different type of, Medicare schedule, or I need something to happen at a national level before I can do anything. He looks around and finds out, what have I got today that I can bring together in order to make things work. And when he would describe an equation, if this is really going to work, what's the equation for making an integrated care system work effectively? Well, you need health and social care teams, potentially, based around real teams, place and pathways by real teams, working teams, activated individuals, carers and families, communities mobilized at scale, and change drivers in the system. And the change drivers in the system, and a lot of these things, are areas where implementation science don't really give us many clues as to how these are actually going to operate. We need leadership, we need culture, we need some system architecture and change drivers in the system, because if we've got those magic ingredients, suddenly we can go forward and develop an integrated care system that is effective. So on the one level, we do know the key elements that make for success. There are a number of different framework models around the world. You've got the looks like a rainbow. It is in fact the rainbow model of integrated care on the left. On the right hand side, a piece of work that I was involved in called Project Integrate. So if you're trying to explain what are the different issues that you need to happen at all of these different levels of integration, from what you do around the needs of patients, how you coordinate care and services across professionals, how you bring together organizations to effectively support the system, what you need to do at a system level. Why? So we kind of know what needs to happen. And the problem is we don't know how they all interact and what you should do first and how you can take these forwards in a particular context. So we kind of know what to do. We kind of know what the key service design features are, and here are some of the things that you'd want to do if you were dealing with complex older people, for example, within a community. These are the sorts of strategies that we know to be successful, and you can look down that list and you can nod your head and you've seen all of these. Not all of them work effectively, but these are the sorts of things that you would need to try to put in place. But unfortunately, we know much less about how to implement things in these different contexts. The program evaluations have shown very limited ability to explain their results. So it's very difficult on a practical sense to take those results from one place to another and think, you know, how do we take things forward? Process evaluations often provide an explanation of the key variables, you know, what actually happened. You know, there's something about the leadership here or something about the culture there, but it's not really explaining what would I do, or what information can I provide to other leaders or to other managers or to other professionals, and what you would need to do as a process in order to be able to bring people together to take it forward. So implementation kind of stops at the abstract scale by saying it was around the leadership or the culture in these sorts of areas that made the difference. That's not so terribly helpful when you're asking a manager to take forward an integrated care program, where they really need to understand the mechanisms practically that they can take forward to make a difference. So what this explains to us is the need for a more intimate relationship, I think, between research and practice in order to understand all of these different implementation complexities. And as I said at the beginning, the reason for that is the forces of inertia. The forces against integrated care, or indeed any other health reform that you might want to put in place in a community, are very strong for all sorts of different reasons. Politics, finance, governance, professional tribalism, social norms and values that aren't shared, different forms of evidence of belief. We don't have enough time. So there's something very important about understanding how to overcome this inertia. What you see in general in terms of health system reforms around the world, the more complex a system it is, the less likely it is to change. One of the things about integrated care and the way integrated care has been put forward as a policy alternative is that other things aren't taken away. So it adds to the system complexity. We'll add a schedule here. We'll add a team over here. We'll do something else with this rural community that adds to what they've already got. And as a result, you end up with layers of complexity, more complexity than you had previously. And that's really not what integrated care is about. You've got to try to make things simpler, more streamlined, more cost efficient. Because if you just add layers of complexity, the forces of inertia just grow stronger and stronger and nothing happens. So if we look into the sort of empirical evidence or the evidence from experience, it all says, yeah, leadership and management, really important. Cultural change, absolutely important locally, crucial to building an enabling environment to make it all happen. And here's a set of phrases that would be recurrent in the integrated care literature in terms of what you would need. Coalition of the willing, inspiring vision, collective leadership, engaging clinicians, all of these sorts of things, fostering collaborative capacity. These are things that are quite well known. And also we can see it in action. So if you go to some of the communities around the world that have actually been able to deliver it over these 3 to 5 years, it's really quite humbling, the sorts of people who are the leaders in that process and how people have come together to create a movement that's changed it. So from left to right, we have the Alaska Native Health System, the Nuka Health System, led by the South Central Foundation, where the local community took the right within US legislation to actually buy out the health system and run it themselves. So it is it only covers around 80,000 people, but it's their own system, and they have consumer owners of that system, and they've changed it from being a very sort of institutionally based system to one based on relationships. So if you go to your GP practice, you don't go and see a GP, you go and see your link worker, and the link worker can access you to a whole range of different care and support services within that setup, including community peer groups and everything else. So they've turned the question around, they come into, what's the matter with you and what can I do about it? And they start having a conversation around their life and their context and trying to understand these issues. And they've had a huge turnaround in terms of hospitalization rates, drug use, and a whole range of different things related to mental health and well-being outcomes. The one in the middle is a community in rural Germany. Again, a population health-based approach over 10 years with a significant effect. So compared to the rest of Germany, you can see that the people living in this community now have an extra 2 years of active and healthy living compared to the rest of Germany, and it's become a much more cost-effective system because they're focusing in on the social determinants of health and how to help people to live well within that community as opposed to the traditional methods. And on the right also saw fantastic, that's Eksote, that's South Karelia, so you can imagine the southeast edge of Finland. Community across about 140,000 people with lots of very small municipalities all dotted about. And they brought the municipalities together, and the older people said, we're pretty scared. We feel alone. We're not getting supported. We don't have the services that we need. So the health and social care came together, and they created a new authority and said, we're going to go out with small teams of a nurse, a GP, a social worker, a couple of other people to go out to these communities and provide them with wraparound services within the municipalities through mobile health clinics and the use of telehealth. And with an experience of 3 or 4 years, they completely turned around the system as a result of that engagement, so that you saw more than 50% less hospitalizations, significant reductions in drug use, increasing levels of satisfaction, more people able to stay healthy and at home, because they've managed to look at the problem and create an alternative solution and understand how to implement it. In all 3 cases, a huge amount of community engagement, professional groups coming together to share a way forward. So these individual case studies all tell you about relationship building and implementation and politics and all the things that need to be put in place to do it. But I suppose, as a scientist looking at this, how do we understand this? And at the moment, I think there was a challenge laid down in an editorial by Trish Greenhow almost 20 years ago now, saying that in the diffusion of innovations like integrated care or other forms of program intervention, there's a lack of any robust understanding about how this can be implemented and sustained across contexts, and there's a need to unpick how outcomes result from that intricate interplay between the component interventions in different contexts and settings. And whilst there's been a growth in research methods that are sought to kind of unpick this, from realistic evaluation methods to behavioral theories and others, they try to kind of understand how, when, and where integrated care interventions influence outcomes in specific cases, but they're difficult methodologies to deploy in practice, almost more theoretical frameworks to understand what happened when and where, rather than something that you can really use. But in the end, simple implementation models are elusive. So I come to the conclusion that when we look at integrated care, or indeed when we look at almost anything that needs to be adopted in a particular context, it's not only the way that we deliver the intervention, if you want to call it an intervention, or the approach, how do we integrate things, it's also simultaneous about the process in which we do it. Integrated care is never a defined intervention. It represents an approach that has a suite of values, principles, and methods and tools that seek to come together in different ways to overcome fragmentation and improve care quality. Therefore, integrated care is an activity. it's about implementation itself. It's about how we do things differently to touch people's lives and make it better. So what that means in terms of us as researchers, it means that the research and evaluation will recognize that there's no discernible difference between the intended intervention and its design and the way that it is implemented. They're part and parcel of the same solution. And this helps to explain a lot of things, particularly integrated care's failure, but also its successes. So if we're really seeking to promote a translational research, as I am, on the Central Coast and beyond, I think implementation science needs to move away from the more generalized explanations of variants to really examine and test these implementation processes themselves. And in order to do that, you need a theory of change. You need to get some sort of understanding around how things are going to change within the context that you're looking at, and use that as a framework for your investigations. A couple more slides. I'll give you one example of a study that we tried to do this in from the European Union. Sustain. So this was a 4 or 5 year European Union project across, I think, 8 different European countries, looking at how we support integrated care for older people living at home. And we ended up with a roadmap. What would we do if I was a manager or professional in a community to make things better for older people living at home? Well, firstly, it's a design question. So we need to understand what the design principles are to support that. But then there's the issue of how would we set it up? How would we assess the environment? How would we design the intervention? How would we implement it? And all of the processes that would need to be understood to be able to implement things effectively. And then the kind of book 3 of the roadmap was all about how do we improve as we go along? How do we create an enabling environment? How do we develop workforce capabilities? How do we bring people together effectively? And it was really interesting because we really kind of got deep into the absolute practicalities of implementation, from how do we hold a meeting and where we hold a meeting, who should be at the meeting, or how's the data sharing, all of the things that you don't really get into. So whilst it felt a little bit prosaic, sort of looking at these things, they're all absolutely essential issues that were coming out of the research that allow people to come together to actually be able to deliver stuff. So it was really interesting to look at the dynamics that some of the system leaders had to put in place in order to be able to make the outcomes more effective within the context with which they were working. And that was really interesting because you got into some really sort of very detailed issues in the different case studies as to how they were able to do things. We just in the end, we fudged the outcome. We just came up with a case book and said, look at these different approaches and make your own, make your mind up. We're just alerting people to the point that these things are really important. Another piece of work that I did was, well, how do we bring that together if we're looking at change management? If we're thinking of integrated care as change management or as an implementation process, what would we do? And on the left-hand side, there might be a number of different steps that we want to take in terms of a change management strategy or an implementation strategy. But at the same time, we also need a relationship building activity on the right. So if the first part of your issue is how do we diagnose the problem together, you might want to undertake a needs assessment and a situation analysis of your needs. But at the same time, we need to start building a guiding coalition of the people who would want to take this forward and build support for the change that you're beginning to initiate. Then in the second phase, you can start to think through, okay, well, do we have a value case in terms of the integrated care that we want to put in place? And how have we developed that with people? Not just sat in a room on our own, dreaming it up on using some form of logic modeling. How do we actually bring people together so that we understand the value case of what we're putting in place, and doing it in a way that really understands the mutual gain of all of the different parties? Because one of the things about integrated care is some people will win and some people will lose. And begin to understand what people's mutual gain is in this. A good example is in the Netherlands, where evaluations looked at the outcome of primary care groups. And primary care groups was a national initiative, I think there was something like 50 or so of them across the Netherlands, which were coalitions of GPs having pooled budgets, focusing on key chronic disease areas like diabetes and respiratory illness and so on. And they use these pooled budgets to deliver and purchase services on behalf of the patients in their geography. And there was a very clear difference between those that succeeded and those that didn't succeed, but it wasn't structural. because all the structures were the same. It was entirely relational. So when you looked at the ones who didn't succeed, the people within those, they didn't feel they were part of something that was bigger than their whole. They didn't understand why they were part of that relationship. They didn't get on with other people. And actually they felt that they were kind of losing out to others, whether that be intellectual property or money or effort. And the things that really made it work were obviously the opposite of that, and the process leadership that allowed all of these people to carry on in these loose alliances and networks in order to move forward effectively. And in the end, it's very unlikely that you have coalitions of the willing when you're talking about integrated care and doing things locally, because you're bringing parties from all sorts of vested interests. Much more likely you get a viper's nest of Machiavellian self-interested parties who at the first opportunity will take and run with the money or the issues for themselves rather than for the whole. You've got to manage that process, and we don't go into it with that kind of change management eye. We assume everybody's in it for the outcome. Well, they're not. So as you develop the value case and you develop the vision and you develop the strategic plan, you've also got to understand, are we really capturing everybody's conflicting interests here in a way that's going to be manageable over time? How do we do that? Then we try to implement it, and then we need to ensure that the monitoring and evaluation is built in right from the very beginning, so that we're able to assess what's going on and have a feedback loop, a continuous feedback loop that is back to the people who are implementing things. And often that kind of embedded approach to evaluation within the service that supports translational research is missing most often. So if I come back with some lessons and then we can have a chat quickly for research, we need assessment frameworks that develop a theory of change in order to be able to help us explain and understand the success of integrated care programs, because it's as much about the implementation as it is about the design. We need to evaluate impact a lot better, so we understand the value created, particularly when it comes to economics, but also in terms of all of the other things that we need to know, because the evaluation of impact is also pretty poor. We need to get underneath, we need to get under the skin of implementation science, look at those black box of complexities, as I once described. So go from implementation science that provides translational knowledge to resolve frontline complexity. And in a recent article, I don't really like the idea of slow science, but what it, in terms of the name, what it really means is a shift in the way, if we want to do translation research implementation science, well, a shift to engaging the end users, health services as co-researchers, prioritizing practical change, local innovation, context specificness over knowledge production in its own right. There's always a place for knowledge production in its own right. But if we want to do implementation science in order to make a difference, I think we need to prioritize, not over prioritize academic disciplinary abstraction over local practical complexity. That's a bit of a phrase, but I think you understand what I'm trying to say there. It's part of my duty at the CCRI to be useful to the community and to the district in the research that we do, and to have impact. And sometimes the work that we do is one step removed from that, and the impact that we have through what we deliver at conferences or what we do in terms of publications, one small step removed from that immediate impact. There's no less value to it, it's just a different way of thinking. In terms of policy, no, we'll go too much into policy because it's more about implementation science here, but problem with policy in Australia in particular is the issue of disjointed incrementalism. As I said before, we just add something and then we add another thing and then we add another thing, and then as post-COVID comes along, so we'll add something else, and the rural floods, we'll add something else. We need long-term thinking to grow system maturity and a compelling vision around what it is that we're seeking to achieve. And the increasing sex and complexity we have is a recipe for inertia. So we have to try to overcome this stasis. And at the moment, integrated care initiatives or population health initiatives or alliances that look promising are cancelled out by other priorities quite clearly. So there needs to be a different form of leadership and management if that is the question that we're seeking to address. And the other lessons are obvious and international. A shift away from the institutional bias to more primary community care-based solutions and engaging with communities, workforce skills and capacity that allows us to do that through coordination and networks and teams, governance and accountability that also supports the ability to integrated care well in local communities, which means devolution and alliancing, different forms of integrated care systems, and bringing closer the funding and delivery of services into more ACO type arrangements. ACO being accountable care organisations, which you can ask me a question on if you don't know those. And then, of course, you've got the funding misalignments that we're all aware of, which can lead to micro purchasing, lack of strategic thinking, care fragmentation. So lots of things that get in the way, but there's still a lot you can do. Lots of evidence to show that if you think in an integrated care fashion, you're more likely to actually deliver care in an integrated care fashion, despite all the system complexities you have around you. So it is entirely possible, in the most fragmented system possible, to have a really interesting care coordination approach, because people have come together to do it that way. And looking at that from an implementation science perspective, or a social scientist as I am, it's fascinating to see what successes they can have. And yet you can have a fully integrated care system over here and nothing gets done, because people don't get on, or a whole range of other issues are in place that don't allow it to happen. So just focusing in on the organisation and governance and policy issues, it's not going to get to where you want to go, because the real issue is what you do at the front line, because that's where the transformative impact, the good stuff happens. So that was a bit rambling, Yvonne, but I'll finish there, and I'm happy to take questions and have a chat.
Thank you so much, Nick. Maybe stop sharing now so we can see everyone on screen. That was fascinating as always, and you mentioned some really interesting case studies. I'm sure there are lots of questions. I've got a couple here in the chat. So Melissa says, awesome presentation. I may have missed it because it was a bit quick, but could you expand on why there is no discernible difference between an intervention and its implementation?
Because the implementation is the intervention. So you're looking to develop an integrated care program. The intervention is as much the way that it is done and how it is done as how it is designed. That's the difference. When you look at any integrated care program, the difference between success and failure is always about how it's implemented. And integrated care itself is an approach to design and implementation. So where I say there is no discernible difference is because the two parts need to be understood in order for you to understand the impact. You can't tease one out. There's an intervention over here, and there's implementation over there. It doesn't make sense to me. And integrated care and complexity tells me that. So that makes sense.
That makes perfect sense. I hope that answers your question, Melissa. The next question is about evaluation. And you know, my passion is to inbuild evaluation from the very beginning, and actually even before the beginning. You know, I believe that formative evaluation is super important. So Kim asks, sounds like developmental evaluation approaches would work well.
Yes, so there are all sorts of phrases for that, but it seems to me that if you're going to, right from the very beginning, if you're going to think through what you might do differently within a community setting, say here on the Central Coast, and you've got a fledgling alliance of the district and PHN and partners, you would want to, right from the beginning, go into a co-design approach, a bit like that change management model that I put up. You know, what are the issues in our community that we really want to solve, and what do we have around us that allows us to understand how we might respond to that? Well, right in that process, you already ought to be thinking about evaluation, because you not only need to understand your needs, you need to understand the audit data, you need to understand the international evidence, you need to bring a whole lot of this information together before you even get to the point where you can start thinking about what your intervention is. So the research is already embedded into the process of thinking about what it is that you're going to do. And then in thinking about what you're going to do, the next step is, okay, what then feasibly is the outcome that we want to achieve over a time period? So you're beginning to develop a monitoring and evaluation framework, hopefully based on some value-based goals related to what you want to have a look at. And there is another one for evaluation, because you're beginning to design not only your outcomes, but how you're going to measure them. And then you start thinking through what the implementation is, and you've got to understand why. Okay, so you're absolutely right. The idea around research just coming in at the back end to understand how things impacted doesn't, again, is suboptimal if what you're seeking to achieve is research for transformational benefit and long-term gain. And it's particularly important. It's not so important if you're thinking about a clinical trial or something that's very clear, but something with complexity, I think it's essential. But we're just learning that, I think, and it's difficult to. This is why I'm very unsuccessful in TRIGS programs, because I keep putting in, we'll do a co-design process. They don't want a co-design process. What they want is an understanding of what you're going to implement and how you're going to evaluate it. So you've got to front load. We've done all the co-design process, and now we're ready to go. Give us your money. So it's really interesting how you have to do that first before you can really start thinking, where am I going to get the dollars to help it? And that requires investment from the parties to understand how that's important. So I totally agree, Yvonne. I think it's for issues like this and others, it's really important.
And I noticed, Nick, you mentioned the triple aim, and indeed I would argue that we need to be increasingly working with the quadruple aim and including those who actually deliver these interventions. Right. So, health professionals, etc., need to be consulted and involved in the process intimately in order for, to make change.
I totally agree, and hence the need to go slower in order to accelerate, which I was trying to, the slow science thing. But also there's a quintuple aim now. Have you seen that? So they've come up with a fifth one, which I think is health equity, which makes sense.
Yeah.
And then there'll be a sixth one and a seventh one, and eventually we'll get to social determinants of health. But absolutely agree, and it's particularly true of integrated care because the workforce dynamics are really very different. Well, actually not very different. Just we're talking about working in teams and across care networks. Creates a whole other dynamic in how that works, because we know that the idea is that we'll put people into teams and everything will work better. Well, the evidence tells you put people into the teams and everything falls apart. It's really difficult. So there's a whole lot of skills, not just in terms of my skill as a care coordinator or my skill as a long-term conditions nurse or my skill to be able to support a person with complex needs. It's also the skill of being able to be part and parcel of working with others. There's a whole lot of stuff in there about the collaborative capacity and the capability of the workforce. It's so essential. So without their engagement in your design, and someone says, in my model, I've got engaged GPs, and the next part of the model is GPs are engaged. That's not going to actually happen unless someone in the room tells you that something has to happen between those two things.
Yeah, thank you. I can see that Frances has her hand up. Frances, you've got a question.
Yes, I do. Thanks very much, Nick. Really nice to see you and to hear you as well. I was really fascinated, and it stuck with me, that idea that you've been talking about, that integration and intervention go hand in glove, and therefore each intervention is so individuated that we can't in some ways make that a sort of shared learning. With that in mind, and I agree with you, I think, on that point, would I be right in saying that the only thing we really can take from that we can share from one another are the barriers to change?
No, I think the issue is there's a lot of yes. I think the point is here you're trying to support something in the context of its implementation. So therefore, the discipline, there is no substitute for being able to understand the complexity within that context. However, what you can bring to the table is all the sorts of things that we know work versus those that don't work across contexts. And we can also understand all the things that work and that don't work around how teams work or how things are developed. So there's a lot of things that you can bring to the table as known qualities of what you're seeking to put in together. However, the point being, you can't necessarily say one thing can be transposed to another.
Yeah.
Because of the differences there. That's the difference. There's a lot that you can bring to the table so people don't have to do all of that work again. But the point being is that, and there's a lot of generalizable knowledge that you can have. Yes, there is. But at some point, that generalizable knowledge has to have a mechanism to find its way into contextual reality.
Thank you.
Okay, I think Andrea has her hand up. Andrea, would you like to ask your question?
Thanks, Yvonne. Nick, that was fantastic. What struck me was that when you're talking about integrated care, some of the early examples you gave were geographical based locations like Cumbria and Alaska. Do you think there are any different challenges when you're trying to integrate care for a particular disease or population? So you mentioned old people, and I know Karen's interest is in motor neuron disease, mine's in sort of treatable but not curable cancer. But is, you know, when it's so important that you mobilize the community and engage people, and is that harder when it's across a larger geographical area like Australia rather than a small defined you know, place like Cumbria?
It's a really good question. So particularly things like rare diseases, you know, you've got to start thinking around, okay, how can we create a network, you know, nationally or even internationally, that allows you to think through, well, what's the best way we can get people access to services in a way that they would prefer. I suppose when you start thinking about population health-based systems, and I noticed, I think someone said on the line, I think it was Peter, is there an optimal size for this? At one level, you see the size of a neighborhood. So a defined community that identifies within itself with 20, 30,000 participants would have within that community maybe a caseload of older people with complex chronic illnesses that could be managed through a small team in primary care. And what you would then do is create, say, across your town or your community of 400,000 people, say a local health district, you might have 10 or 15 of these working together. I think one of the reasons that it's so important is that there's no substitute, I think, when you come to some of these things for implicitly understanding the needs of your local community, which is why GPs and community staff and people who are embedded in those communities are so really important, to tell you the realities of how things work. And you need to be able to have that kind of eye to how you do things, but you need to weigh up that neighborhoodness with, you know, how do we actually able to fund a response that allows us to be able to capture the needs of the population that we're trying to serve within that. It's a really hard question. So when you look at the better outcomes, so like the Cumbria one is an interesting example. You've got 20 small community groups around a population of 750,000. In the Basque Country, you've got something like 12 integrated service organizations across a population of about 3 million. You look at other schemes. So there've always been these issues around how we organize the geography of things. But in the end, the importance here is you need to have engaged communities, and you have communities who are able to engage with you. So the size depends on your capability, depending on what you're looking at, for people to be able to respond. And it's particularly important in things like the management of complex chronic illness, because the more you're able to put a movement in, the more you can bring in industry or the church or anybody else that you want to bring into that equation to support, the better it is to be done around a community that people know and understand. So there's no, when you look, for example, I'll give you an example, and this is the evidence from healthcare homes. I call them healthcare homes in Australia. It's a model of around, only covered about 10,000 people here in Australia, I think. The healthcare home, patient-centered medical home model in the States has become a very popular approach. And I don't know how many of them are there, but there are lots. But the ones that work better are the ones that had geographic population coverage, because the idea of a patient-centered medical home is you look across your community to all of your people to find out what are the priorities that matter. And you can target the people who are most at risk of a hospitalization or something, and you focus your services around that. And you give them what, the idea is you give them whatever they need in order to keep them healthy and at home. Whereas the ones that are picking off disease focus might do well on a particular disease. We're great at COPD, but woe betide the person who's got COPD and a mental illness because they don't have any support from a psychiatrist or a psychologist. So it's difficult to answer your question, but if we assume that a good outcome requires engagement of the community in order to make it happen, it necessitates a place-based approach in order to make that happen. That's particularly important as you get into the more difficult issues that start to address things like social determinants of health and your ability to have a community where your future health and well-being is as dependent on things like roads and infrastructure and jobs and education and all of these sorts of things, which some of the bigger population health-based approaches start to get into. And integrated care just becomes a delivery mechanism in order to make sure things are coordinated. So you look to the really big schemes like the Robert Wood Johnson Foundation, turning around the fortunes of the people of Baltimore, for example, in the metropolitan communities there. Yes, the service was much more integrated around primary care, but it was all of these other things that you're able to put in because you were doing a geographical approach. The German system that I put on Kinzigtal is only about 70,000 people in a rural community. And it started off with the usual suspects, diabetes, COPD, chronic disease management, but it created a movement around these 70,000 people. So actually it's become more like a sort of a healthcare brand, and they do all of this amazing population health work, and you've got sanitation, you've got water, and you've got leisure clubs, and you've got all of this sort of stuff. And you can't tease out one particular variable, but what you see is a much more cost-effective system from a healthcare spending point of view, people who are living longer, and people who are living longer in better health in a period of 10 years. Absolutely transformational. Now, I can't necessarily put a finger on that and to say it was this that did it, but it was a way of instituting one kind of approach of working together and working through that over a number of years to create a really quite amazing outcome. So if you could capture and bottle that, and thinking of doing it in different places around the world, I'm sure things will be better. But it's just, as I said to you before, I don't know how they did it. It's not being captured. I would love to find out, because in the end, you end up with the usual suspects. It was leadership and culture. Well, thanks very much. I need to know how you did it. And they don't know themselves. Sometimes it's just luck. Sometimes as well, if it's luck, it's luck. But I want to find out about it, because I can't talk to my chief executive and say this is how the alliance should work unless I tell him these are the sorts of processes you need to put in place to get people together effectively to do it.
I think a lot of what you just said goes to, I'm getting a huge echo from someone. It goes to Hossai's question, which was around, is integrated care more like social change rather than the healthcare system transformation alone? And I would argue, of course, health alone will not achieve change. You actually need change to society, and people need to be supported. People need to have means to and access to safe housing and food and self-determination.
Yeah.
Also, did you want to comment on that?
No, thank you, Bob.
Okay. One last question, I think. Very fitting from a health economist, Delia. From a funding perspective, can integrated care be cost neutral from the start, or must there be an investment of funds to reap cost savings down the track?
That's a very good question, because there's been a lot of emphasis on the ability to put upfront money in order to make savings later. And indeed, quite a lot of people saying that's essential part of integrated care because we've got to put in all of this change management and blah. I'll give you an example of Oregon. The whole of the state brought together its trying to create something really quite amazing by pulling together all of its different budgets, and it persuaded the US Treasury to give it $1 billion in advance for transformational change on the basis that they would save 3 or 4 billion in 10 years' time, which they didn't, of course, but that was the idea. The answer is it can certainly be cost neutral from the start, and in fact, that's the way you should be thinking. If you assume any form of intervention requires you to put money up front, you'll misspend it. So the John Howarth scenario that I put up was one where you look around as if you're in disaster medicine and say, what can I use today? It's not going to cost me any more money in order to take these things forward effectively. That doesn't mean if you've got a bit of money to seed things in where you might want to use that money, but that money is almost always misspent. What is it that we need? We need a new data integrated set and invest lots of money in data. Well, maybe, but how are you going to use it? Are you really going to use it? Or we need to have, we need to invest in 3 integrated care managers. Well, an integrated care manager is not going to work in a disintegrated system. So you're giving an integrated care manager a job with no hope of them being able to deliver what they should be asking to deliver. So you can be very careful if you're going to put money into the system where you want to spend it. So you need a very clear theory of change and a model to understand we've got this money, where do we want to put it? And too often you just select the person who's going to be a manager and select the person over here. And there's not enough thinking that goes through it. So I much prefer an approach that says, let's start from a cost neutral basis and work out what we're going to do, because it stops people staring and blaming everybody else. And it's perfectly possible to do that. And they did that, funnily enough, in all three examples that I showed you, the NUCA system, the Kinzig-Tal system, and the system in Finland. None of them started with a big investment of money. What they did start with a long-term commitment. And certainly in Germany, they started with, they did get the data because they wanted to demonstrate things, but that got given to them free. So cost neutrality, I think, for me, is really important. Other people would disagree. But I think for me, in terms of implementation, getting things going for the long term, if you're starting with nothing different, then actually you have a much clearer conversation around where you need to go. Because if you start giving people money, where's that money going to come from? Whose money is it? Where do we spend it? Who do we spend it on? I'm losing out, you're gaining, you're getting a computer, I'm not getting a computer, you're getting a nurse, I'm not getting anything. You know, I've seen this happen, and it's a bit like joining two disparate organizations by a joint spreadsheet. It doesn't end well.
All right. Thank you so much, Nick. And thank you everyone for coming along. I'm sure you found this session really rewarding and fascinating, and always amazing to hear from Nick. I hope you can all join us in a month's time. So on behalf of the Executive Committee, Andrea, Stephanie, Bella, Karen and myself, thank you so much everyone, and thank you, Nick. If you think that some of your friends might like to view this webinar, it will be on the AIHI website, and you can view it at any time. Is that right, Bella?
Yeah, it'll be up on the AIHI YouTube, I think. Yeah.
Yeah.
Fantastic.
And Yvonne and colleagues, send me the invite to join your group. I know I'd love to come to other webinars that you're doing if I'm allowed.
That would be lovely.
Yeah. And I'll probably be doing that work with Karen on motor neurone disease, so we'll see what comes up with that. Small one, but it might lead to a bigger project.
Yeah, we should hold a webinar on using some Australian examples. I noticed
well, there are some.
Yeah, there are some.
Quite a few good ones, but
yeah, including from the Central Coast. Yeah.
Mm-hmm.
All right, fabulous. Thank you so much, everyone, and have a good rest of your day. I'll see you in a month's time.
Thanks, Yvonne. Thanks, everybody.
Thanks, Yvonne.
Bye.
Thanks very much. Fantastic session.